Hello and welcome to Conceptual Surgery, and the topic that we are going to discuss today is retroperitoneum. It's a very important topic from MS surgery and DNB surgery point of view. I'm Dr. Anubhav Vindal from Maulana Azad Medical College. The first disease which affects the retroperitoneum, which is very important, is retroperitoneal fibrosis. Although it is a rare diagnosis, but it is one of the most common afflictions of affecting retroperitoneum, apart from retroperitoneal tumors. So what happens is there is development of a flat gray or white plaque of tissue which starts in the central area and then spreads to the paravertebral spaces. And it starts usually at the level of aortic bifurcation and then travels cephalad. So this fibrosis is confined in the central and the paravertebral regions, and therefore trends to encase the aorta, the inferior vena cava, and the ureters, which are the structures which are running in the central and the paracentral locations in the retroperitoneum. Now you can understand encasement of the aorta, encasement of the inferior vena cava, and encasement of the ureters can have catastrophic clinical presentations. Usually, the fibrosis is confined to the space between the aortic bifurcation, which is present at the sacral promontory, and the renal arteries above. The histological appearance on biopsy may vary from active inflammation with a very high cellular content to totally fibrotic presentation with bundles of collagen and acellular and mature fibrosis. In fact, many of these patients may actually have elements of calcification interspersed with fibrosis in the plaques in the retroperitoneum. Most of the cases are idiopathic in origin, and there is no actual cause found in these patients. There are different causes which may have the same presentation in the form of retroperitoneal fibrosis. So retroperitoneal fibrosis is the ultimate umbrella clinical presentation of several benign and malignant conditions. What are the benign conditions? It could be idiopathic, which is the most common and which is sometimes known as Ormond's disease. It could be chronic inflammation due to any cause. It can be secondary to extravasation of urine, which causes inflammation and fibrosis in the retroperitoneum. It could be irritation in the retroperitoneum due to a leakage of blood or intestinal content. It could be secondary to inflammation of aortic aneurysm. It could be secondary to trauma, and some drugs like methylsergide, which is not used anymore, and some chemotherapeutic agents can also give rise to retroperitoneal fibrosis. Malignant causes like lymphoma, carcinoid tumors, and secondaries from carcinoma of the stomach, colon, breast, and prostate can all present with retroperitoneal fibrosis. So you can see there is a large gamut of conditions which can present like in the common way of fibrosis in the retroperitoneum. What are the clinical features? The clinical features are obviously, because it is not a single entity, so the clinical features are varied, and there is an ill-defined chronic backache in these patients. And the main clinical features are due to compromise in the function of the involved structures. So if there is compromise in the lumen of the aorta, there will be ischemia of the part of the body which is supplied by beyond the aortic bifurcation, so the lower limbs. If there is compromise in the lumen of the IVC, there will be compromise in the venous return from the lower half of the body, which may present as lower limb or scrotal edema and the edema of the lower abdominal wall. And if there is compromise in the lumen of the ureters, there can be obstructive uropathy, which may ultimately present as chronic renal failure. How do you manage? The primary treatment goals are 4. One is to stop the progression of the fibrosis and inflammation in order to prevent damage, ongoing damage. Second, in case there is ureteric obstruction, you have to prevent and relieve ureteric obstruction. Third, in case there is florid systemic inflammatory response, you have to inhibit and stop it. And fourth, in case there are any constitutional manifestations, you have to improve the constitutional manifestations to improve the generalized well-being of these patients. So the usual agents which are used for modification of disease activity, because the cause is generally in 70% of the patients, the cause is not known. So it is empirical in the form of steroids, and studies have shown that tamoxifen may also have some beneficial effect in these patients. How do you restore the flow in affected structures? So in case there is ureteric obstruction, you can either do indwelling stenting of the ureter, or in case it is extensive or you are not able to pass an indwelling stent, you may have to do an open ureterolysis, in which this plaque is cut, the ureter is released from the fibrosis, and it is transposed from a retroperitoneal position to an intraperitoneal position. In some of these patients, the surgeon may also like to wrap the omentum around the ureters in order to safeguard the ureters from any further inflammatory process. Next is retroperitoneal abscess, which is again an umbrella presentation of so many different disorders. It may be primary in case the infection results from hepatogenous spread and lodges in the retroperitoneum, which is a rare condition. Secondary if it is related to an infection in an adjacent organ, which is the more common cause of most of these abscesses. The most of these secondary infections arise as an inflammatory process in either the kidney or the GI tract. So you know that many of the components of the GI tract are retroperitoneal, that is like the duodenum is retroperitoneum, then the cecum, the ascending colon, they are retroperitoneum, then the descending colon is retroperitoneum. So any infection which is arising from these components of the GI tract can present as a retroperitoneal abscess. And most of the urinary system, that is the kidney, the pelvis, the ureters, they are all retroperitoneal structures. So the renal causes of infections, they may be related to stones or previous urological operative procedures. GI causes could be in the form of appendicitis, diverticulitis, pancreatitis, and Crohn's disease. So retroperitoneum is a huge space. So you can see the retroperitoneum is actually a continuation of the extraperitoneal space anteriorly, which is between the transversalis fascia and the peritoneum, which continues posteriorly in front of the posterior, the retroperitoneal muscles, and is continuous across the midline onto the retroperitoneal space of the opposite side. So infection of the kidney can burst into the paranephric space and then into the retroperitoneum. It may track along the muscles and may go onto the exterior. Abscess in relation with the vertebral column may also track retroperitoneally, and an abscess and infection in relation with the colon can also track into the retroperitoneum. Likewise, the duodenum and the pancreas, which are also retroperitoneal structures, can give rise to secondary affliction of the retroperitoneum. The most common symptoms include abdominal or flank pain, fever and chills, malaise, and weight loss. So non-specific signs and symptoms. So therefore, it is very, very important to diagnose this disease correctly, and the most important investigation is cross-sectional imaging in the form of a CT scan. A CT scan will help you to make a diagnosis of a retroperitoneal abscess, will give you the location of the abscess, which will tell you the relationship with the organs surrounding it, and also the likely source of infection in case you are able to pick up a surrounding organ which is also appearing inflamed. The treatment is directed towards the primary cause and includes appropriate antibiotics and adequate drainage. So pus anywhere in the body, the treatment is drainage. Another related condition to the retroperitoneal abscess is Psoas abscess, and in India it is mainly caused by tuberculosis of the spine, what is known as a pot spine, whereas in the West it is mostly secondary to direct spread of infection from either GI tract or the urinary tract. Especially in patients who are immunocompromised, like intravenous drug abusers or HIV positive patients, primary abscesses due to hematogenous spread from an occult source are the most common variety. The clinical presentation is non-specific, may include lassitude, fever, and back pain in these patients. Some of these patients, especially in late stages, may present with groin swelling because the iliacus is a continuation of the psoas muscle. So this is a psoas in the flat body of the pelvis, the bony pelvis lies the iliacus, both of them joined to form a common tendon, which inserts medially on the medial aspect of the thigh at the